Доброго дня, шановні колеги. Ми починаємо нашу чергову лекцію. Ви знаєте, що започатковано в університеті в рамках ініціативи «Об'єднані серця з Україною» цикл лекцій провідних фахівців з усього світу. Ми вже заслухали лекції європейських професорів, це була Великобританія, Бельгія, Нідерланди, Італія. Сьогодні ми маємо честь анонсувати підтримку цієї ініціативи медичним університетом Геттінгену, це Німеччина, це один із найстаріших університетів Європи, який був заснований в 1734 році англійським королем Джорджем. І є, я вже сказала, одним із найвеличезних університетів. Його засновниками, або як фундаторами, були родичі барона Мюнхгаузена, всім вам відомо. Крім того, в цьому університеті є 45 випускників, які стали лауреатами Нобелівської премії. І з 14 із них вона була вручена безпосередньо в університеті. А такими відомими видатними випускниками цього університету це були Карл Гаус, Майк Планк, браття Грім, Артур Шопенгауер, вони працювали. Отто фон Бісмарк і, так сказати, курс пройшов Ілля Мечников. І крім того, в тому університеті курс пройшов Олександр Вікторович, професор Курятник. Я зараз це скажу, а потім Оксана буде переводити. І сьогодні в нас така честь нам, це представник університету, професор Тім Зідлер. Він є виконуючим обов'язки директора клініки Серця Медичного університету Геттінгену, фахівець внутрішньої хвороби з кардіології, генетичної діагностики в галузі внутрішніх хвороб і керівник програми інтервенційного лікування клапанів серця. Ми раді вас вітати, шановний Тім. Я надаю слово Оксані для переводу в першу чергу для вас.
Dear students, dear colleagues, we welcome you, and we are continuing the cycle of lectures within the framework of an initiative United Hearts with Ukraine, and which has already been joined by leading European professors from United Kingdom, Belgium, the Netherlands, Italy. And today we have a honor to announce the support of this initiative with University of Göttingen, and which was founded in 1734 by English King George II.
Recording in progress.
This is one of the leading classical European university, and 35 graduates from this university was Nobel laureates, and among them 14 graduates was awarded within the walls of university. And among the outstanding graduates include Karl Gauss, Max Planck, the brothers Grimm, Arthur Schopenhauer, Otto von Bismarck, and even our Ilya Mechnikov.
Alexander
And our Professor Alexander Kryatov was also in this university, professors learning during more than 1 month. And the interdisciplinary cardiology center of Göttingen is represented by 14 clinics and institutes of medical center of University Göttingen, and they are working together in the field of heart diseases, blood vessels, lungs, and kidneys. And the clinic of cardiology and pulmonology is headed by prominent professor Gert Hassenfuss. And the topic of today's lecture is valvular heart diseases, and it will be present by Professor Tім Зідлер, a deputy director of the clinic, heart clinic of the University of Göttingen, and it's specialized in internal medicine and cardiology, genetic diagnostic, and head of interventional heart valve treatment program. Dear Professor Tім Зідлер, we welcome you. We're happy to see you.
If it's possible, one words. Nice to meet you, dear teams. I want to thank you first of all for your time, for your lectures. I want to thank the Professor Gerd Hassen, who's the director of Heart Centrum Göttingen. I have the possibility to have been twice in the Göttingen University, and I remember the warm on the Göttingen. I remember the brilliant specialist lectures, and we understand one doesn't mean heart centrums. It's the prominent centrums in the world, in the Europe, and thank you very much one more for Professor Hassen for the kindly response for our request and agree to cooperate together. Thank you very much, team, and thank you very much for Professor Gerd Hassen.
Thank you very much. Welcome, ladies and gentlemen, dear students, dear colleagues. First of all, maybe a quick question. Can you hear me? Can you see the slides?
Yes, we can hear you and we can see the slides.
Excellent. So thank you very much for the kind introduction. My name is Tім Zідлер. I'm Vice Director of the Department of Cardiology here at the University of Göttingen. And I think the place here was introduced very well, very kindly. I feel very honored that on behalf of Professor Hasenfuss, our head of department, I can talk to you today. I'd like to mention that for us, it's really a great honor to take part in this lecture series, United Hearts with Ukraine. And I can assure you, in our hearts, we're all with you, and we are in full support of your brave fight against the aggression. And we all follow the news. We followed the terrible attack on January 14th, and it's very hard for us to see that there's so little we can do. And given this background, it's really important, I think, to say thank you very much for the opportunity to deliver this tiny gesture of support. So in the next 30 minutes, I will talk about a topic which is quite specialized. And I understand that the audience is a little bit mixed. Not everyone will be becoming a cardiologist. I understand there are also quite a few medical students on board. We have younger doctors here in Göttingen. We also have the whole spectrum of training, if you like. So I try to provide a bit of an overview about the spectrum. I am an interventional cardiologist, so I decided to talk about something that I know a little bit about. It's going to be a little bit detailed in some parts of the talk, but I start a little bit broader with some background information on mitral regurgitation, pathophysiology mainly. Then I go over the principles of specialized catheter-based therapy for mitral regurgitation, give some scientific background and evidence, and talk a little bit about patient selection, and then hopefully we will have some time for a discussion. So this is my motivation slide, if you like. It's always good to know why you should follow the lecture, why it's maybe useful to listen. Well, my argument is that mitral regurgitation is the most prevalent valvular heart disease. This is data from Germany. You can see the prevalence in Germany, but that is also applicable to Europe and therefore also for Ukraine. It's a disease of the elderly. Once you're 75 years old, you have a good chance of having some form of mitral valve disease. The numbers are comparable to aortic valve disease, but a little bit higher for the mitral valve. In the hospital, the prevalence is a little bit different. We treat more patients with aortic stenosis, and mitral diseases are second. This is because aortic stenosis is more severe in terms of the prognostic impact. So the likelihood of dying from aortic stenosis is much higher. But mitral disease is very important because the impact on quality of life is very, very severe. So it's worth spending the next 25 minutes maybe with mitral valve disease, and this is what I decided to do. And before I go into the details of treatment, I'd like to recapitulate the pathophysiology, and I will do this in quite some detail. So please excuse that this slide will be a little bit lengthy, but it's also fun to remind ourselves of the pathophysiology of mitral valve disease, also because it is applicable to all kinds of mechanisms in heart failure. I will do so by going over the pressure-volume relation. And just for those who are not so familiar with this, this is a coordinate system where you, on the right, have the volume in the left ventricle, so the left chamber, the heart, and here on the y-axis is the pressure in the left ventricle in millimeter mercury. So no time in this coordinate system, just pressure and volume. And you can see here at resting conditions, so in diastole, there is a certain relation between volume of the left ventricle and pressure. When the ventricle fills with blood, of course, a little bit of pressure builds up. And here at this stage, this is the end diastolic pressure. It's exactly the time before the myocardium starts to contract, so in end diastole. Next thing that will happen is the myocardium contracts, the heart beats, so pressure builds up in the left ventricle, but volume remains the same for a moment, simply because the increase in pressure is still below the aortic pressure, meaning the aortic valve is still closed. Once the pressure exceeds the pressure in the aortic valve, then the volume in the left ventricle is reduced. Pressure builds up despite the volume goes down a little bit throughout systole and then falls back again until the aortic valve closes and diastole is about to start. We have then isovolumetric relaxation phase, and this is the complete cycle. So this is the physiologic situation, just as a reminder. And we will see soon how that changes in mitral regurgitation. In mitral regurgitation, we fear forward failure. Forward failure means there's not enough blood supply for the organs, and that occurs from various mechanisms that I will go through. First of all, in mitral regurgitation, there is, of course, backflow of blood to the left atrium. And this regurgitant volume that goes through the atrium cycles back to the ventricle in the next diastole. So we have a continuous futile cycling, a certain volume that just goes backwards and forwards between atrium and left ventricle in the wrong direction and then back again. And of course, this leads to a decrease in cardiac output because this part of the stroke volume is missing for supply of the organs. This is compensated by neurohumoral stimulation like adrenaline, vasoconstriction, but also neurohumoral stimulation leads to sodium retention, and that again leads to fluid retention, and that compensates for the decrease in cardiac output, but at the cost of an increase in preload that is associated with more work for the heart. Obviously, if you have some futile cycling and you compensate for this volume that is going in the wrong direction, you have to perform more cardiac work. And you can see this here in this pressure-volume relation, that we start from an increased preload, so left ventricular end diastolic pressure is increased at this stage. We start more right on the pressure-volume curve here. Then we have very performant systole. We have a lot of stroke volume. Stroke volume is in fact the distance from here to there. You can see this with the red arrow, as opposed to the physiologic stroke volume, which is much smaller. And this is possible as a compensatory mechanism because the heart generates more work. And the work is the area under the curve here in green. And you can see that the area here is much larger compared to the physiologic area. So cardiac work is the area within this loop, and it's obviously increased. So increase in stroke work, increase also then in energy consumption of the myocardium and substrate requirements. And this goes up to a certain amount where energy can simply not be supplied according to the demand. This is less a function of the coronary arteries. It's more a problem within the cellular mechanisms that the mitochondria are simply not capable of supplying enough energy for contraction. And this again then leads to negative remodeling with left ventricular dilatation. An increase in wall tension is the result of this dilation of the left ventricle. And according to Laplace law, then you have a decrease also in wall perfusion and start with a vicious cycle that leads to wall apoptosis or myocardial apoptosis and fibrosis. And in the end, you end up with low output failure. So this in quite some detail, the pathophysiology of the forward failure in mitral regurgitation. There is also backward failure, and don't worry, it's not going to be that detailed again now, but backward failure is equally important in mitral regurgitation. Again, it starts with regurgitation of blood in the wrong direction towards the left atrium. You then have a rise in left atrial pressure, of course, and that leads to increase of pressure in the pulmonary veins, in the pulmonary capillaries, and of course, then also in the pulmonary artery and right ventricle. So pulmonary hypertension is a consequence that also is associated with a decline in alveolar diffusion. And this results in the prominent symptom the patients describe, which is dyspnea. There may be also atrial fibrillation as a result of the rise in left atrial pressure, left atrial fibrosis, and as I already mentioned, right-sided heart failure, leading to the full picture of congestive heart failure. So this is what the pathophysiology is in a nutshell about. And it's important to maybe go through these steps because we wonder how we can help these patients. What might the treatment be? And indeed, in fact, we have a lot of tools already in the box that can address the pathophysiology. Imagine increased preload. We can address this with diuretics. So sodium and fluid retention can be counterbalanced by prescribing diuretics. And this is, in fact, a very efficient drug in mitral regurgitation. We can also address neurohormonal stimulation with beta blockade. We can even address the more advanced stages of heart failure development like apoptosis and fibrosis with ACE inhibitors. And this is a very important message of this lecture. The medical therapy of mitral regurgitation is very efficient, very important, and always comes first before we go to any catheter-based interventional therapy. In the end, my talk will be about also about interventional therapy. And as an interventionalist, we already, we are working in the heart, if you like. So we need to know our anatomy. And I also have a brief excursus here to this to the anatomy. For the medical students, once again, we have two leaflet valve, and we have a mitral valve apparatus that is comprised of the chordae tendineae, the papillary muscles that communicate with the myocardium. The whole mitral valve is also dependent on the more distant anatomy. Imagine if the left atrium is enlarged, then that leads to enlargement of the annulus here. So the valve is dependent on several structures in terms of function. If we're working on the mitral valve, if we do an intervention, we have a convention how we display the valve. We always look from top to bottom. So as if we would cut open the left atrium, and this is what the surgeons do if the surgeons operate. So they look from top to bottom, and this is called the surgical view or the surgeon's view. So this is now as if we cut open here. We look here on the right on the top of the valve, and you can see that the anterior leaflet is very large, whereas the posterior leaflet is a little bit more narrow, and in between is the opening possibility, or the intercommissural line where the two leaflets meet each other. On the bottom, you can see a transesophageal echocardiogram. This is how we do the interventions. We, of course, we don't open the chest. We interact with the patient via imaging, and the imaging is performed with the transesophageal echocardiography. This is also why these interventions are done in anesthesia, because it's quite hard to tolerate the transesophageal echocardiography for a longer time. Before we come to interventional therapy, I would just like to briefly introduce the concept of primary versus secondary mitral regurgitation. It's sometimes important to distinguish between these two entities. Now, what is primary mitral regurgitation? Primary means that the valve or the valvular apparatus is affected directly by the disease. As you can see here, there's a rupture of a chordae, and that leads here to a little prolapse of the posterior P2 segment, leading to mitral regurgitation. So the valve is directly affected. Primary mitral regurgitation is any etiology with intrinsic lesions of the mitral apparatus. So the leaflets, chordae, or papillary muscles, and these intrinsic lesions drive the regurgitation. And as opposed to primary, secondary mitral regurgitation means that the valve and the apparatus is intact per se, but more remote pathology affects the valve. For instance, here you can see an apical myocardial infarction that leads to dilation, and this dilation then leads to transmission of force to the chordae and to the valve. So a constant pull on the leaflet, if you like, and this leads then to incomplete closure. So changes in geometry of the heart with impact on the mitral apparatus is what is basically the pathophysiology of secondary mitral regurgitation. Just need to skip to the next slide. Okay. I hope you can see these movies. This is an example of primary mitral regurgitation. You can appreciate here there's a large prolapse of the posterior P2 segment, like in Barlow's disease. And on the right, the same heart, you can see that the result of this prolapse is that you have an enormous mitral regurgitation. So this would be an example of primary mitral regurgitation. Secondary mitral regurgitation, once again, is a disease of the more remote parts of the heart that indirectly affect the mitral valve. You can see here there's a very delicate interplay of various forces. You have forces that are working on the chordae tendineae. You have an annular force that is opposing dilation. You have atrial forces. And of course, you have forces coming from the pressure within the chambers. Whenever one or more of these forces are disbalanced, they are out of balance, then very often you end up with secondary mitral regurgitation. Now, what can we do interventionally about these primary and secondary mitral regurgitations? I'll show you a little movie, and you can see in blue the regurgitation. So blood is flowing into the wrong direction. And this is the device that we can use to repair the mitral valve. It's a long catheter, and in the end, there is a little clip. In this case, this is called the mitra clip. It's a transvenous procedure. So we advance a guide wire through the vena cava inferior to the right heart. And as you can see here, we then puncture the interatrial septum and advance a guiding catheter to the left atrium. From here, we then advance this tiny little clip. And with this clip, you can approach the valve. You have several degrees of freedom, so you can directly position the clip where the pathology is. You then advance the clip through the valve, and then you can see that we call this procedure an edge-to-edge repair. So edge-to-edge repair means that we grasp the free edges of the anterior and the posterior leaflets. As you can see now, we close the clip. And if we're not happy because there's still some regurgitation, we can reopen it, reposition it, and try to find a position where we address the diseased part of the valve efficiently. You then end up with this double orifice that you can see here. Of course, you have to make sure that you don't create a mitral stenosis, but you can effectively use 1, 2, or sometimes even 3 clips without having a stenosis. And if you're happy with the result, you detach the catheter and the procedure is completed. This is an example of transcatheter edge-to-edge repair. Here in this little movie, you can see if there's a primary mitral regurgitation, you can address this by directly putting 1 or 2 of these clips here to the pathology. And if it's a secondary MR, the procedure is not that much different. Of course, usually there are outward forces that you'd like to antagonize. You have, as a result, this large regurgitation along the intercommissural line. So usually you try to address this by positioning 1 or 2 or sometimes even 3 clips right in the middle to address this pathology. Quite efficient usually. This is an example of a secondary mitral regurgitation now, and you can appreciate that the left ventricular ejection fraction is really reduced. You have dilation of the left ventricle, so a classical secondary mitral regurgitation. Again, on the right, you can see the enormous regurgitation. These implants come in different flavors. You can have small and large ones, narrow and broad ones, and there are 2 companies that supply devices. And this is another example where you can hopefully see a large and high-grade mitral regurgitation. And you can compare the picture on the left with the picture on the right. And here on the right, you can see the result after the implantation of 1 mitral clip. And you can see that the mitral regurgitation is almost completely eliminated. So very good result. Okay, now, what is important to mention is that it doesn't make any sense to repair moderate mitral regurgitation. This is a trial from the surgical colleagues where they randomize patients to mitral repair or just CABG without mitral repair in moderate mitral regurgitation. And you can see there's not much difference in terms of survival. So the lesson here is invasive therapy is only indicated for symptomatic high-grade mitral regurgitation. What is high-grade mitral regurgitation? Of course, this is an echocardiographic diagnosis. And I don't want to go through the details here, but you can remember that 60 mils of regurgitant volume define high-grade. And that applies to both primary and secondary mitral regurgitation. Sometimes it's easier to measure the vena contracta. And this is also, of course, a valid approach. Okay, now, in the last part of my talk, I'd like to come to the evidence, to the science we have for this intervention. And I would like to start by saying that trials examining surgical repair or replacement did not reveal a reduction in hospitalization or mortality in mitral regurgitation. So despite the fact that we do surgery quite frequently, there's not much evidence for this. Medical therapy is, as I already mentioned initially, very important because it's very efficient, as is the cardiac resynchronization therapy. So whenever we address the mitral valve, we have to make sure that medical therapy has been optimized. There are 2 trials comparing the edge-to-edge repair, the catheter-based therapy that I just highlighted, with medical therapy, and I'll show you the results now. The first trial is called the COAPT trial. And unfortunately, my slides now here it is. So first of all, this is the COAPT trial. This is a prospective randomized single-blind trial. It was an open label trial, but randomized, prospective, published in New England Journal of Medicine already in 2018. And it shows, first of all, that this procedure is safe. So mitral edge-to-edge repair is a safe procedure, very little adverse events. It also showed that it's a very effective procedure. This is the result of the control group versus device group for hospitalization for heart failure. And you can see that it's almost half the event rate when you perform mitral clip. So we have almost half of the hospitalization rate in the patients treated with the mitral clip. Very good result. And you even have a significant reduction in death from any cause. This was, again, a significant result and quite markedly that this intervention is so efficient. So the authors concluded that mitral clipping had a low rate of hospitalization, lower mortality, and also a better quality of life and functional capacity compared to medical therapy. Follow-up was 24 months. It's important to mention there's a second trial also published in New England Journal of Medicine. It's called the MITRA-FR trial, and this trial was neutral, so no improvement in hospitalization for heart failure. And this is, of course, fun to have two trials with two different results. And in my final minutes, I'd like to go over this discrepancy and maybe discuss why these trials were different in terms of outcomes and what we can learn from this. But first of all, the neutral trial, the MITRA-FR trial, had the problem that the edge-to-edge repair was performed before the medical therapy, the guideline-directed medical therapy, was optimized. And in contrast, the very successful COAPT trial demanded that the medical therapy needed to be optimized before randomization. So there was a 3-month time window for up-titration of the drugs. And this is an important difference. And I think this reminds us that the medical therapy is very, very important. And as I already mentioned, this addresses the pathophysiology so nicely. So we always have to do medical optimization first before we even think about edge-to-edge repair. Another difference was that the MITRA-FR guys were less efficient in terms of reduction of regurgitation. So less success in the reduction compared to COAPT. And this is because almost any French center took part, and there were many little experienced operators. In fact, it was allowed to take part if you had done 5 interventions in your life, then you could randomize patients. And from my own experience, I can say that experience is very, very important in this intervention. So this is a problem. And also the inclusion criteria were much broader in MITRA-FR. There were patients with very end-stage heart failure, end-stage right heart failure, and of course, then it's not to be expected that an intervention at the mitral valve is successful. If the ventricles are so damaged already and in end-stage fibrosis, for instance, and enormously dilated, then I think this therapy comes too late. And so I think we can conclude that guideline-directed medical therapy comes first, and this is also part here of the ESC guideline. 1B recommendation, it's important to select suitable patients, namely those who are in high-grade MR, but not end-stage heart failure. And whenever we do not meet both requirements, we end up with 2B level of evidence C recommendations, so very little evidence for any intervention. I will skip this slide for the sake of time and come to the conclusions. I think I already mentioned that COAPT was very successful, but here you can see the exact figures. The absolute risk reduction for all-cause mortality with MitraClip was 17%. So this is absolute risk reduction, not relative risk reduction, and this equals a number needed to treat of 6 patients to prevent one death within 2 years. That's a very good number. The patient's characteristics were about similar, but the hearts were more dilated in mitral FR, and there were more patients in right-sided heart failure. There's also one thing that you may have heard of. It's called disproportionate MI. Disproportionate MR means that there is a very large regurgitation, whereas the ventricle itself is not so diseased. These, of course, are patients that benefit more from the intervention of the valve, and these were more frequently included in COAPT. Another important difference between the two trials were carefully selected centers. And this is my last slide, and it goes back to the patient perspective. I think that's very important that we always ask ourselves, are we doing something meaningful for our patients? And maybe you remember that I said that the quality of life is really affected by mitral regurgitation a lot. This slide shows you a measure of quality of life, namely the Kansas City Cardiomyopathy Questionnaire. This is a questionnaire that addresses multiple aspects of quality of life in patients with heart failure. And 5 points increase over baseline mean a meaningful improvement in quality of life. And you can see now all kinds of medical and medical interventions and also structural interventions, like the dapagliflozin trial or ivabradine with the SHIFT trial and many others. And you can see that the COAPT trial that I introduced today leads to an enormous improvement in quality of life. You can only achieve such an improvement with structural interventions. You can see here, for instance, the partner trials. These are the trials for the transcatheter aortic valve implantations. So these are really very powerful interventions, but it's sometimes worth it because you gain much more quality of life compared to medical interventions. And I think, therefore, it's nice to be able to provide this intervention to some patients here. And with that, I'd like to close and thank you very much for your invitation once again and for your patience. I hope it wasn't too specialized. I hope you learned something about mitral regurgitation, and I would be very happy to take your questions in case you would like to ask something.
Yes, doctor, I do have a question.
Okay.
The first question is, what is the role of acute...
Excuse me.
Дякуємо, шановний Тім, за дуже корисну і для нас цікаву доповідь. І якщо ви дозволите, то будуть питання від наших слухачів, студентів. Дякуємо.
Dear Tim, thank you, dear professor. Thank you for your brilliant lecture. It was very interesting for our students and is very useful. And if you agree, we can start a session of question and answers. Yes?
Yes, please.
Thank you very much.
Thank you very much.
Dear students, do you have questions, please?
Dear students, you can ask your question to professor.
Okay, doctor. I was going to ask, is it possible to use novel or new anticoagulants in patients after we've given them a heart valve replacement?
That's a good question. Maybe I can say for the conventional heart valve replacements, like biological or artificial valves, it is definitely not recommended to prescribe the new anticoagulants. Valvular heart disease is an exclusion, so vitamin K antagonists remain the mainstay of treatment for these patients. For the mitral clip procedure, there is no need for anticoagulation. These patients are just treated with platelet inhibitors, in fact, with a single platelet inhibitor after half a year. So it's nice that there's no recommendation to have a full anticoagulation in these patients.
Thank you very much, doctor.
Welcome.
I have the questions, please.
Hello, I have a question. What is the differences among the patient's prognosis after mitral valve and aortic valve replacement? Prognosis.
The prognosis. I'm not sure that I can fully answer this question. I'm not aware of a representative trial for aortic stenosis that includes the whole spectrum of patients. We have, of course, the partner trial that compared medical therapy to TAVI, for instance, but this was performed in patients with very high risk. And all the other trials compared aortic stenosis therapy with TAVI compared to surgery, but there was no placebo group or medical group. So it's a bit hard to compare it, but of course we have data from the COEP trial with this very effective improvement in prognosis. And we have long-standing data for aortic stenosis that it's also associated with a large improvement in survival. But to compare both, we would need to have comparable groups of patients, and I'm not aware of a direct comparison. Of course, aortic stenosis is associated with a much worse prognosis. So conservative treatment in aortic stenosis is associated with a very poor prognosis. The mean survival in severe symptomatic high-grade aortic stenosis is 2 to 3 years. Whereas in mitral regurgitation, the prognosis is much better. So I think both interventions, or in both cases, surgery has its justification, but it's hard to compare. I hope this answers the question.
Thank you.
I have another question. That you told that about a COEP trial, and what is if we compare the COEP trial and the CABG in mitral regurgitation?
I'm not aware of a comparison of, or maybe I don't understand the question exactly. You mean CABG compared to mitral repair?
Yeah, the COEP trial.
But what would be the point to compare survival? Are you worried about complication of the therapy?
Yeah, survival.
Yeah, the survival after mitral repair, like in COEP, was almost 99%, even though the patients were, so just after the procedure, if we're talking about procedural complications, this is an intervention which is tolerated very well. So even though the patients are quite sick, they are in heart failure because COEP was secondary mitral regurgitation. The procedure is very safe. And of course, the CABG procedure is associated with a little bit higher mortality, depending on the cohort. Once again, it can be in the range of 2 to 3% mortality, acute mortality.
Thank you very much. Dear student, do you have questions?
I have just one question. Do you have any information about cases or chances of rupturing the valve implants after the treatment?
Good question. There are cases, yes, where you can, where you unintentionally damage the valve with the MitraClip procedure. This can happen. For instance, if you overdo it, if you apply too much force on the valve, if you really want to antagonize these outward radial forces and you grasp a lot of valve material, then you can damage the valve. This occurs, but it's very infrequent, but there are reports where this happened. So the clip can then deattach, and this is an unwanted complication of the procedure.
Thank you very much for your answer.
You're welcome.
Thank you very much. Dear students, do you have questions for Professor Tім?
Yes, I have a question.
Yes, please.
Hello, doctor. Doctor, recent studies and literature show that there are high risk of perioperative interventions for mitral regurgitation. So what would be the right time to intervene or conduct procedures like COAPT?
I would say that the best time would be the time that meets the inclusion criteria in COAP, because this COAP trial was so successful and the MITRAP-R trial was not very successful. So I think it's good to really stick with the inclusion criteria. And the most important inclusion criteria in terms of timing were that the mitral regurgitation needed to be moderate to severe or severe. This was the inclusion in terms of severity, but it's also a matter of timing, because you can very well wait with moderate MR. You don't have to intervene with moderate MR, but once it's moderate to severe or severe, then the time is right. A second criterion was symptomatic patients. So patients needed to be in New York Heart classification 2 or more severe. So asymptomatic patients should not be subjected to this treatment. I think these are the two most important criteria. And on the other side of the disease spectrum, patients that are too sick should be excluded. And this was the case in COAPT, and that contributed to the successful results. One aspect was a very enlarged left ventricle with the left ventricular end diastolic dimension of more than 70 millimeters. These patients were excluded from the intervention. So not too sick, not too good. I think then it's the right time.
Thank you very much, Tim. Excuse me, dear Tim, do you have time for some questions? Ed?
Yes, I can still answer a few, of course. Yes, I'm happy.
Thank you very much. Thank you. Dear students, do you have the questions? One question, if possible, from me. Would the several age for patients, for replacement mitral valves and maybe TAVI system? What's the difference approximately age in Germany for these patients? And maybe several questions concerning differentiation between choosing cardiosurgery procedure or maybe intervention procedure for aortic valves and mitral valves.
Yeah, this is a very important question, of course. And I start with the mitral valve. The catheter-based therapies are still new. And so we don't have that much experience compared to surgery. That also means, and this is also what the guidelines recommend, that the MitraClip and the other catheter-based procedures are reserved for those patients which are elderly, which are which have a high risk when they are operated with conventional surgery. So we usually calculate the Euroscore, and if it's above 4, then we tend to recommend the clip procedure in secondary MR. So it's not always age, it's also, of course, the condition of the patient, and mainly it's the surgical risk. In high-risk patients, we would prefer the catheter-based approach. In low-risk patients, usually under 75 years, we would prefer the surgery. And one important aspect is that in primary mitral regurgitation, the surgical results are really, really good. So with primary MR, we are even more strict with performing this procedure only in those who are inoperable. So if a patient can still be subjected to surgery, we would recommend surgery in primary mitral regurgitation, whereas in secondary, this is a little bit more relaxed indication. With the aortic stenosis, it's the guidelines are a little bit different in the US and in Europe. In Europe, it's recommended over 74. So once you're 75 years old, TAVI is the primary recommendation. If you are below 75 years old, then surgery is the recommendation, provided you have a low surgical risk.
Thank you.
That...
Thank you very much. I want to ask you concerning sometimes epidemiology aspect. What is the majority reasons for mitral clips, for example, infection, endocarditis, maybe inflammations, and for aortic stenosis? What is approximately epidemiology reasons for this procedure and appears the valvular diseases?
Unfortunately, the connection was not very good. Can you say that again? Are you asking the complications of the procedures?
No, I want to say I ask concerning the epidemiology reasons. For example, we know that for aortic stenosis, the main reasons for TAVI is the calcinosis. And unfortunately, for surgery procedure, infection endocarditis. For example, for mitral valves, what's the main reasons for operations for maybe difference between the cardiovascular surgery and the mitral clips?
Yeah, in terms of the etiology, it doesn't make so much difference as long as it's secondary mitral regurgitation. Well, then the etiology is most of the time a dilated cardiomyopathy or an ischemic cardiomyopathy with dilation of the left ventricle. That's the most common etiology, and we wouldn't make a distinction between surgery or the clip procedure based on the etiology, as long as it's secondary MR. With the primary MR, this is quite frequently Barlow disease that leads to the primary mitral regurgitation. So connective tissue disease is the most common reason. If it's an infective valvular disease, then we would never perform the clip procedure. Then this is really an indication for surgery. And this, of course, also applies to the aortic valve. You're absolutely right. In 9 of 10 cases, it's more or less the atherosclerotic mechanism that also affects the valve. So we have calcium deposits, a degenerative mechanism, and this can be addressed with TAVI or with surgery. But if it is something else like valvular endocarditis or rare conditions like pure aortic regurgitation as a result of dilation of the aorta, then we would always recommend surgery.
Thank you very much. Dear students, maybe appear new questions. Tim, is it possible? I know that you collaborate and work together, cardiology and pulmonologists. Because we have the questions concerning the situation after COVID-19. What's your experience concerning demand antibiotic prophylaxis if the patients suffer the pneumonia, for example? And maybe mitral clamps and TAVI will be the additional options for antibiotics prophylaxis in these patients, this pneumonia after COVID.
Yeah, in pneumonia, we don't do antibiotic prophylaxis in patients with artificial valves anymore. The recommendations have been downgraded a few years ago. They are really restricted to certain interventions in the dental area. For instance, if there is blood exposed to teeth or the gum, then we have a recommendation for antibiotic prophylaxis. But for infectious diseases, even if it's severe, like in pneumonia, it's not generally recommended to have antibiotic prophylaxis.
It's very important and it's very interest. Thank you very much. And if it's possible, the last questions concerning COVID. I don't know that in Germany, but in Ukraine, we see more patients that suffer acute myocarditis after the COVID. This appears a heart failure, this decreased injection fractions. And my questions concern the time. that we choose for additional estimate patients concerning meteorological agitations. In this patient, it's severe acute myocarditis, and this usually 6 months or more for additional estimate concerning the demand control the mitral eclipse if they appear the mitral regurgitation after COVID myocarditis.
Yeah, to be honest, we here in Göttingen, we have seen a few patients with myocarditis after COVID, but it wasn't so frequent that I would feel comfortable to really say this is something that we observe like once a month or so. It was less, I think. Even in the severe cases, yes, I can remember a few patients, like 5 or 6 patients with myocarditis, but not that many. So maybe this depends on other factors or so. Our COVID program was quite large, but all in all, yeah, I haven't seen this so frequently. So I don't feel so comfortable to really say something about
It's good. Yes. It's good. So thank you very much. Thank you very much for discussion.
Шановний Тім, ми вас дуже дякуємо за те, що ви погодились провести цю лекцію. Дуже цікава, корисна. І ми розуміємо, що ті технології, які були вами представлені, вони є на теперішній час найсучасніші. На жаль, вони не доступні поки що в Україні, але ми завжди сподіваємось, що колись і ця технологія прийде до нашої країни. Ми вам дуже вдячні.
Dear Professor Tim, thank you very much. We were grateful for you for this lecture, for you this opportunity to hear you, and it was very valuable for us and for our students. And we believe that in the near future we will have these technologies in our country, and we will learn our students for this maybe future technologies in Ukraine. Thank you very much. We're very grateful for you.
Thank you very much, dear Professor Tim, again for your support Ukraine in the very difficult times for us. Thank you very much for brilliant lectures. Thank you very much for wonderful discussions and your times for answer questions from our students will stay in Ukraine in this very, very difficult times. For us, it's very sincere. We feel the sincerity from you, and we see the Ukraine language. Велике спасибо. And we want to say you vielen Dank. Vielen Dank. Danke für Ihre Unterstützung. Wir hoffen auf eine weitere Zusammenarbeit. So thank you very much. Thank you very much.
Thank you so much. It was a great honor and pleasure. Please, I would also be hoping that we'll find a way to repeat this maybe another day and have another lecture. I wish you all the best. Keep on with your brave fight. We all admire you, your country and your attitude. It's a great inspiration in a way also to us. And we are very thankful for the sacrifice that you do. Thank you very much, and it was a great pleasure. Bye-bye.
Thank you.